The last area we need to talk about for prevention of pressure injury in the critically ill is how to improve the tolerance of tissue for pressure and shear. You and I both know that patients that are equally ill, both have the same surgery, both have the same comorbidities, don't both ulcerate. So what's the difference in those patients? Well, it's probably in part the tolerance of soft tissue and skin for pressure and shear. Let's look at some of those factors. A significant aspect in the critically ill patient is malnutrition. Not every patient who comes into the hospital has been adequately nourished up to the moment that they were hospitalized. There are a fair number of patients who sit at home in a recliner chair hoping their chest pain will go away, hoping their difficulty in breathing will get better. And then a couple days later, they finally decide, you know what, I think I need to go in. Well, they've probably not been eating during that time. So they enter our hospitals catabolic or breaking down their stores of protein and fat in order to survive. We know that the catabolic process is very rapid in patients, occurring within a number of days after they've used their easily accessed stored glucose. They start to resort to breaking down body stores of protein and fat, and it's measured by the amount of nitrogen in the urine, a waste product of protein metabolism. When we don't feed patients quickly and adequately in critical care with these major illnesses, we contribute greatly to the risk of pressure injury because the body cannot repair simple injury to the skin because it's catabolic. I want to offer you some ideas for improving the nutrition of the critically ill. So the best way to feed them is enterally, either by mouth, if they're awake and can appropriately chew and swallow safely, or by tube feeding if not. And it's really important to use the gut if it works to augment the nutritional status. You get more than just nutrition by feeding the patient. You actually get a reduction in infections by feeding the patient adequately. Now, one of the things that happens in the critically ill is we shut the tube feeding off for a sundry of reasons, right? We shut it off because the patient has meds that are incompatible. We shut it off because the patient needs chest physical therapy, going to CT, whatever. The way the orders are written, though, nurses can't make up that time. So let's just for easy math here, let's say the tube feeding's at 100 an hour, and you have to shut it off for a couple hours on the day shift. Well, you can't just add 200 mils later on. They're missing that dose. So probably the better way to do this is ask the physicians for an order of a total daily volume, so 2,400 mils. And that way, if you have to shut it off on days, you can make it up on nights because you're missing that. Or you can pre-plan that the majority of the tube feeding will be given on the night shift when they're not going for CT scans and they're not getting meds that are incompatible. It allows you a little flexibility, and you may not have to double the rate. You may just be able to increase the rate over several hours to make up for the missing hours. Obviously, you need to prevent aspiration, so the head of the bed often goes up, sometimes higher than 30 degrees, up to 45 degrees. If that's the case, the risk of shear is there, so be sure you get dressings on the sacrum of the patient. And be cautious that you're aware of the nutritional risk really from the time the patient's admitted. We shouldn't be waiting for 5, 6, 7 days to feed these patients. Nutrition is a huge aspect of pressure injury prevention, but a huge aspect of healing in general. So nutrition really can't be overlooked or minimized in the critically ill. Microclimate is a term that we use to describe the heat and humidity between the skin and the surface of the bed or the linen. And when it's warm and wet, the skin actually absorbs that fluid and then becomes very intolerant of pressure and shear. So we need to control the microclimate. That is to keep the skin clean, dry, cool, so that we don't have a risk of maceration of the skin. So we need to make sure that we're using linens and incontinence pads that are compatible with the bed. So we purchased a bed with microclimate features. You've got to have a breathable underpad under that patient. Otherwise, you're blocking the microclimate. You can't be layering the bed with 4, 5, 6 draw sheets because you're blocking the very feature that you want, which is to keep the skin clean and warm and dry by using the extra linen and the plastic incontinence pads. If you have patients that are obese or have large skin folds for other reasons, you can get intertriginous dermatitis. And when they're not moving, that tends to get worse. So I want you to think about using a wickable fabric, often lined with silver, and it will really help clean up the skin folds. Pillowcases, draw sheets, towels do not work. They don't wick, they hold the sweat in the skin fold and increase the risk of maceration. If you're seeing severe skin injury from exposure to hydrochloric acid from a G-tube, exposure to liquid stool from diarrhea, you're going to want to treat those with a skin sealant, and cyanoacrylates are some of the best that are around. It will seal directly to the open skin and provide a barrier to reduce the risk of infection. One of the risk factors for pressure injury in the critically ill is ischemia, brought on largely by vasopressors. And so we need to protect the skin in patients who are on vasopressors or having other cardiovascular events that lead to hypotension or poor perfusion. COVID-19 has actually also shown us a lot of accelerated clotting in patients, rendering their skin ischemic. If you didn't have a chance to see the first set of slides that we have in this series, I have some pictures of COVID skin that may look familiar to you. That's ischemic skin. Ischemic skin needs protection. Put the patient in fleece boots that elevate the heel. Keep the body warm, so more than one draw sheet across this patient, please. Make sure that that ischemic skin is not injured, so very little trauma. Using hard boots on patients can increase the risk of injury to the ischemic limb, and those wounds do not heal without adequate blood flow. So do protect the skin in the ischemic patient to improve the tolerance of skin for pressure and shear. What we've looked at in this section is a package of interventions through 4 components: reducing the intensity of the pressure against the skin and soft tissue, the duration of the pressure, the shear and friction against the skin, and then helping the skin improve its tolerance. Hopefully through those 4 domains, you can find areas to improve your practice. Having Kathleen Bowman join us for this section was very enlightening, wasn't it? She has a wonderful way of explaining the world of the critical care nurse. Please stay with us for part 3 when we look at how the systems can respond and reduce the risk of pressure injury in critically ill people.